Hello, my name is Michelle Panetta, and I am an OMIC risk specialist. Today I'm going to be talking to you about telephone screening, liability issues, and guidelines. The goal of any healthcare risk management course is to provide ophthalmologists, technicians, administrators, basically the eye care team, with information that will help you provide quality care to patients while minimizing the risks of lawsuits and claims. This course focuses on liability and patient safety issues that arise in the context of assisting patients who are calling your office or contacting you after hours by telephone. These guidelines and materials being provided were adapted in part from Academy publications. The Physician's Guide to Eye Care and Ophthalmic Medical Assisting, an independent study course. OMIC's risk manager Ann Menke took information from these publications and worked with OMIC consultants to produce sample contact forms. The objective of this course and the guidelines is to provide a resource to assess your own telephone screening procedures and protocols and templates for you to implement in your own practice. The major issues we will cover regarding telephone screening include the various roles and responsibilities of the staff and the ophthalmologist, what services can be delegated by the ophthalmologist to staff, the protocols that you will implement in your office, and the protocols that you will have in place to handle after-hours calls. The handout and resource material includes the basic information to build your procedures and protocols. We provided overall screening guidelines and a patient telephone screening form that prompts staff to ask specific questions. We also have developed complaint categories that can be used as a starting point in developing your own. We have a form that will aid the physician and administrator in assessing the skill level of staff who are answering the phone. And finally, we have provided an after-hours telephone contact form and a sample sheet from the patient care phone call record pad. So why are we so concerned about telephone procedures and protocols? The telephone is the primary means of communication between patients and healthcare providers when they are not meeting face-to-face in the office. Patients are calling to report problems, make appointments, seek advice, refill medications, discuss billing issues, comment or complain about care. The staff are usually the first point of telephone contact for patients, with some exceptions that we will cover later, and the physicians rely on staff to screen these calls. Staff are acting as agents of the physician. They are an extension of the physician and part of the practice. After hours, the practice continues to receive calls from patients and others. Many offices have a staff, tech, nurse, and optometrist triage calls, but every practice needs to have the ophthalmologist actually available to handle calls after hours and a plan in place to handle. There also may be after-hour calls when covering for another ophthalmologist or the practice or the emergency department. What is the risk challenge? So you receive all these calls and you're operating at a disadvantage. You don't have access to all the information you have from seeing the patient in person. You certainly aren't able to use your instruments, but you simply cannot see the patient. This may be changing with some of the smartphone technology, internet technology, but this is still limited. The patient may be a poor historian and you don't have the nonverbal communication cues that let you know the patient is confused or not understanding your questions. Some patients who call may be unknown to the practice. When the ophthalmologist is taking a call, you may be trying to screen and assess a patient from whom you have no medical records. Ideally, with broader implication of electronic healthcare records and health information technology, remote access to records will improve. Given the frequency of telephone contact with patients and the wide variety of reasons patients call, it is important for the practice to define the specific roles and responsibilities of the physician and staff. As I will address in this course, we strongly recommend policies and procedures that include written guidelines for telephone screening. Many times when patients are calling you, you need to treat the situation as you would an office visit. You gather the information from the patient about the problem or from staff at the ER. You let the patient another physician, a patient's parent, know what the next steps that will be taken are. For example, schedule an appointment, prescribe medication. Finally, you document the encounter and the basis of your decision. The staff are the first point of contact, and they generally begin the information gathering process on behalf of the physician. Therefore, the physician must help develop and oversee the written protocols for telephone screening so the physician gets the information he or she really needs. A physician in practice will want job duty descriptions that define telephone screening responsibility. And of course, these will be specific to your patient population if you have a multilingual, elderly, handicapped, etc. Your subspecialty, if any, and the various type of staff, optometrists, techs, nurses, etc. Because I work at a medical malpractice insurance company, I look at the world in context of litigation against ophthalmologists. Who gets sued when a patient is injured? Almost always an individual physician. Therefore, when a patient is injured and telephone screening is an issue, the ophthalmologist will be examined about their supervision of staff. We would like them to be able to testify that they have a system in place in their office to train and verify competency of telephone screening, that staff are trained to consult with the ophthalmologist as needed, that the practice has a policy in place regarding a daily or periodic review of telephone calls. Certainly not every call needs to be brought to the attention of the physician, but the physician should make clear which one should be. These screening protocols and guidelines are not set in stone. They should be revisited. When they are reviewed and or updated, the date should be noted and the old guidelines should be archived. The practice of medicine. When setting up screening protocols, a physician needs to keep in mind what only physicians can do. Diagnose mental and physical conditions, use drugs in treating patients, perform surgery, use other methods in treating diseases. There may be some exceptions in various states regarding mid-level providers such as physician assistants, optometrists, nurse practitioners. We want the physician to understand the tasks only he or she can perform, their scope of practice. From a liability perspective, we want the physician to avoid allegations of aiding and abetting the practice of medicine without a license. We don't want the physician to put the staff in a position where they're practicing beyond their training or licensure. When in doubt about what staff can do, the physician can contact the state licensing board. It might be the medical board, the state nursing board, or the board of optometry. When training the staff, we should learn and understand that they are gathering information. After training, they will be able to assign an appointment category, and when in doubt, will know who to ask for guidance or who to forward the patient to. They will be trained to complete contact forms. Some of these will be electronic, and which ones the physician will want to see. Importantly, the guidelines and screening training will alleviate the burden of staff making independent decision about patient care. Instructing the staff. Along the lines of not making independent decisions, staff will be trained to not give medical advice or an opinion, but staff should be trained to give instructions and communications to patients depending on their role. So if a post-patient calls and wants to know how to perform some post-operative self-care, staff can instruct the patient on how to properly rinse the eye with sterile saline solution. I think there's a natural tendency for people to want to be reassuring when someone calling is in distress. Some practices go through role-playing so staff can learn certain phrases to use that show sympathy and concern and avoid statements that might be interpreted as minimizing the patient's complaint or be misleading. Showing that such training and orientation took place is overall helpful for the practice and will go a long way to refuting patient plaintiff claims that staff told the patient nothing was wrong. Staff should be trained to follow written guidelines or have a document that will help them ask questions to ascertain a patient's level of distress. The following slide is an example of a patient telephone screening form. It contains many of the basic screening questions staff would want to ask patients. This is just a template, but may be useful in providing you with ideas for the form you use now. Any template would have to be customized for a specific practice. The guidelines might be posted by the telephone. They might be embedded in the electronic healthcare record. There are quite a few questions on the template, but the reality is that staff may be able to assess the patient's problem very quickly and know how to categorize and handle. The physician and the practice may want to categorize certain complaints. The following is a list of complaints that OMIC uses on its screening guidelines. Vision loss, vision changes, pain equals flash floaters, burn equals foreign body, trauma, injury, redness, discharge, other eye complaints. The idea behind categorizing complaints is to help staff determine when a patient will be seen. We are on the side of having the patient seen sooner if any complaint falls into the emergent complaint category. Slide 21 is a form that was developed at OMIC. It's a telephone screening category form. Basically, we found that when we developed the categories of emergent, urgent, and routine, there was a great deal of discussion regarding what sign or symptom falls within each category. This is something that each physician in practice will have to develop with feedback from staff so that it will be useful for the patients and the practice. Interrupting the physician. Each physician in the practice should reassure staff that it's okay to interrupt them under certain circumstances or conditions. A lot depends on the patient flow and the structure of the office. A physician may only want certain staff to interrupt him and only under certain circumstances. Whatever conditions are decided upon, the main goal is that staff and the physician understand this protocol the same way. Patient same-day requests. Ask staff to inform you when a patient request to be seen the same day can't be accomplished. Again, how are these requests handled? Who handle them will vary depending on the practice. At times, a physician may want to speak to the patient personally. It is really going to be up to the physician and vary with the reason the patient wants to be seen the, quote, same day. If a same-day appointment cannot be provided, staff will want to direct the patient to an appropriate source of care, perhaps their primary care provider or co-treating ophthalmologist. If a patient is adamant and the practice simply cannot accommodate the patient's request, the patient can be advised of their right to seek emergency care at a hospital for their emergency medical condition. New patients. Whether a practice accepts new patients will vary. If you cannot accept a caller, it's important to train staff to limit their discussion of the patient's condition or complaint and clearly state what they need to seek, that they need to seek care elsewhere. A brief statement that to the caller that was directed to other resources is all that needs to be documented. When staff have questions, as mentioned earlier, the staff should be encouraged to consult with you, but put limitations around it. Some examples may be situations that are not listed on the screening guide or fall into more than one category. Examples: complaints that are not listed on the screening guide, routine patients that want to be seen that day. When staff have questions, as mentioned earlier, the staff should be encouraged to consult with you, but put limitations around it. Some examples may be situations that are not listed on the screening guide or fall into more than one category. Staff qualifications. You will want to make sure that staff have the necessary skills to screen ophthalmic problems. Some of the telephone skills being patience, professionalism, as they represent the practice, and ability to follow guidelines. Patience, cheerfulness. Some practices use a telephone assessment form, like the one shown in Slide 27. To make sure that newly trained staff have learned how to communicate well with patients and others over the phone. Communicating with patients about prescription refills is something all staff should understand. The ophthalmologist documents the dosage, routine, etc., and this information is available in the patient's medical record. When the patient calls or the pharmacy calls or contacts the staff, they'll check the patient's medical record to verify if the patient is authorized to have a prescription refill. Staff will verify the date of the last visit. There may be laws that stipulate the maximum time, for example, greater than 1 year, that drugs can be prescribed without another examination. If so, staff will be instructed by the physician that the patient should be seen. This will all be documented in the patient record. If the ophthalmologist approves the refill, staff will contact the pharmacy with the authorization to refill. The physician will initial or sign the authorization. Postoperative contact protocols. Postoperative patients should always be understood as potentially high-risk contact. OMIC has handled a number of cases where patients allege their calls to physician and staff were mishandled. Good documentation becomes key. As well, each practice will want to carefully orient staff on dealing with particular types of postoperative patients. An example would be cataract versus oculoplastic patients. Documentation that staff were properly trained has also been a key issue in successfully defending cases involving the handling of postoperative patients. Ideally, you will want patients and their caregivers to be provided with postoperative care instructions. These instructions are something that the staff and physician have developed. When patients call, they should be asked if they still have their instructions. An example would be diet, activity, wound care instructions. Staff will gather the information about the date of the procedure and the patient's complaint. These contacts are ones that the physician will generally want to review on a daily basis. Many times, these patients are put directly in touch with the physician. Next, we will review a case study. This case study involved a postoperative care and patient handoff situation, and it will illustrate the importance of documentation and clear communication between the providers. This patient was a 53-year-old man seen by a retinal specialist. He had a very prominent posterior vitreous separation in the right eye. 2.5 months later, the patient complained of spots in the right eye and was diagnosed with a retinal detachment and a giant tear. He had a vitrectomy and fluid gas exchange, and his post-op pressure was 27. He was considered doing well. 2 days later, on a Saturday morning, the patient called the insured who was in the car to say that his eye felt different. The insured said the patient denied upset stomach, nausea, or vomiting or pain. The insured said he told the patient to increase his medication, and he mentioned he was going out of town and his partner was covering for him. None of this was documented in the patient's record. On Sunday, the patient called the partner who was covering, complaining of feeling pressure and seeing black. She knew he had a gas bubble 3 days prior, so was concerned his patient was on steroids. She wanted to see him the next day in the office. At the office visit, the patient complained of nausea and vomiting during the night. He was no light perception with lid swelling. His pressure was 60. The lens and iris were against the cornea. She decompressed the eye. She continued to treat the eye, but the pressure remained high and the patient was no light perception. The final outcome was light perception vision. Finally, however, the eye needed a prosthesis. To complicate matters, the patient developed a retinal tear in the left eye. Legal issues. The patient sued alleging negligence and specifically alleging the patient was abandoned. They allege the surgeon failed to provide for necessary medical care when he left town. Remember that the surgeon stated his partner was taking call. The theory of the plaintiff was twofold. The surgeon should have seen the patient on Saturday and not left town. The covering MD was inadequate because she would not see the patient on Sunday. When OMIC analyzed the case, there were clearly significant damages related to the right eye, the lost vision, and the need for a prosthesis. Although unrelated to the care provided by the surgeon and his partner, the left eye was also losing vision. When evaluating damages, which is basically the amount of money to settle if there is liability exposure, there was a significant wage loss in this 53-year-old man, and there was no cap on pain and suffering damages in the state at the time of this lawsuit. The factors affecting the decision to go to trial or settle include an internal review by an OMIC physician consultant and experts retained by defense counsel. The OMIC reviewers were concerned that the surgeon did not communicate with his partner and that the patient had called the day before with complaints about the eye feeling funny. The experts retained by the defense attorney for the insured felt that the two calls taken together were sufficient that they should have suspected a rise in pressure and seen the patient right away. The credibility of the plaintiff was good, but so was that of both physicians. However, there was no documentation supporting either physician's version of what the patient had described. The insureds were advised that this case would be difficult, but not impossible to defend. The insureds requested that the case be settled and they not be taken to trial. Now I have a question for you. What do you think is a reasonable amount to pay the plaintiff to settle this lawsuit? We will let you act as a claim committee on slide 45. While you don't have all the facts about wage loss, you do have an opinion on what the case might settle for. Do you think it's A, $75,000, B, $275,000, C, $500,000, or D, greater than $1 million? The correct answer is about $275,000. This was a very large settlement on OMIC's books when it occurred. Now let's discuss the risk management issues, specifically patient handoffs. The Joint Commission said that ineffective handoff communications recognized as a critical patient safety problem in healthcare. The handoff process involves senders, the caregivers transmitting patient information and releasing the care of that patient to the next clinician, and receivers, the caregivers who accept the patient information and care of that patient. When you are covering for another physician, good idea to identify high-risk patients. Discuss the recent surgeries, unstable patients, patients who have already called to report a problem, and then be very specific. Clarify when you will go off call. Additional risk management handoff issues. Documentation is key. It promotes continuity and the defensibility of care. Keep after hours and on-call contact forms with you. We have a sample, and document each patient contact. Document your decision-making process and document the patient handoff. Risk management issues, again, when you're going off call, contact the physician for whom you're covering. Identify the patients who called, fax the contact form, and keep the original copy of the contact form in an on-call patient contact file. Slide 49 is an example of OMIC's after-hours on-call telephone contact sheet. The document promotes you to ask about recent procedures or surgeries, whether the patient has contacted any other healthcare providers about the same or related problem, and it's important, calls to other healthcare providers that should be treated as a red flag. After-hours documentation. When going off call, place the contact form in the patient's medical file, assuming this was a patient in your practice. When providing on-call coverage for a physician in another practice, tell the physician when you go off call fax or scan and send a copy of contact forms and other records, if any, and retain the original in your file designated on-call coverage for contacts. Slide 51 is an example of a patient care phone call record pad. Believe it or not, these are quite popular at our meetings, and there's a high demand for them. There's about 20 pages per booklet. The things that I am able to provide for you that I think are very important in summary of this presentation are sample screening guidelines, the patient telephone screening form, and the document that talks about emergent, urgent, and routine cases, and the after-hours on-call telephone contact form. I appreciate your time today. I hope that you have enjoyed this session. If you have any questions, feel free to contact me. My contact information is on slide 54. Thank you.